Does anyone have any questions before we get started? I will record this. Let's see. I've got to stop sharing and record it first. Any questions? Okay. Let me start recording and then share my screen. Okay, there we go. Yep. There we go. All righty. Okay. So the taking in period is when the mother is taking in being a mother, basically. It's normal for her to be a little hesitant and rely on others to help her in all the decision-making process. She's kind of passive and very dependent and pretty preoccupied with her own needs. She's interested in getting something to eat and sleep. And this can be misinterpreted as not bonding with the baby, but it is a normal phase or normal period in the, the time right after delivery. So she's just taking in the whole idea of being a mother and getting used to the idea.
Miss Chandler.
Yes.
I didn't mean to interrupt you, but I don't know if it's just on my end, but I still see where you pulled up Blackboard to get the PowerPoint. I don't see the PowerPoint.
Okay. All right. Thank you. All right. Okay. Let me stop recording for a minute. And okay. See. All right, let me stop sharing because I got to record again. Okay. How about now? Everybody see it?
Yes, ma'am.
Okay,
yes.
Thank you so much for letting me know. You also want to look at cultural considerations. Are there cultural practices that the mother wants to practice and adhere to while she's in the hospital after delivery? So what foods can she eat? Some cultures have certain hot and cold rules, can't drink cold water, only warm liquids. And so we need to know those kinds of cultural practices that they want to adhere to. And they think that if they do this helps them with the healing process. So it's always good to ask them about any particular cultural practices that we need to be aware of. If we look at the European heritage, they expect to eat a full meal and have large amounts of ice liquids after birth. They believe that food restores energy and fluids help replace fluid loss during labor and delivery. And they may even want to get up and walk around shortly after birth, shower and wash their hair. Our Islamic culture are very modest, as you've heard before, And so they tend to want to be totally covered except for their hands and feet. And no man other than their husband or family member should ever be alone with them. So that's good to know. Some cultures emphasize the certain postpartum routines and rituals designed. Oh, I told you already about that, the hot and the cold balance of the body. If we look at the Hispanic culture, African and Asian cultures, they may avoid cold after birth also. This includes like cold air, wind, and all water. So they also want warm water, or at least room temperature. Some traditional Mexican descent cultures may avoid hot foods. And it's not the temperature of the food, it's just considered, or certain foods are considered hot foods and cold foods. So they would consider pork a hot food. So they would avoid pork. In many cultures, the extended family plays a real essential role in the postpartum period. So the grandmother may often be with the mother, taking care of them, taking care of the mom and the infant, and is thought that, she brings wisdom and experience with her. If we look at the Orthodox Jewish women, they also want to maintain their modesty and keep their hair covered. The first 7 days they're given special treatment and cared for also by family members. And typically they want to request a kosher diet. Rest is crucial for the first 6 weeks. They typically breastfeed, and the baby, if the baby is male, he won't be circumcised until a later date. And also the baby won't be named till a later date. So if we look at the care during the 4th stage, which is the postpartum period, of course, if it's a vaginal delivery, there's going to be perineal discomfort. So we want to get ice on that area. So get an ice pack to the perineum for the first 24 hours. And this is very important to reduce edema. And it also has a numbing effect. So it's a pain relief. It helps with pain relief. After first 24 hours, we suggest warm sitz baths. In other words, they sit in warm water. And we've got these little sitz baths basins that they can be given. And this also helps get rid of the swelling, helps with the pain, promotes circulation to that area, which also promotes healing. We want them to be using what we call a peri bottle and rinsing themselves off every time they go to the bathroom with warm water, just plain warm water. And then patting dry. We want to make sure that they understand to pat dry from front to back. Then typically they're given also Dermaplast spray, which you've all looked up. And that is, just a numbing spray that helps with that tender area. And also Tux pads, which is witch hazel pads, help with that area. They're also great for hemorrhoids. So if they're, they can line those up on their pad and put some in the front and some in the back, and that will help both areas. If the mother has decided she does not want to breastfeed, we want to definitely make sure that she has a tight, and I think I've already talked about this, but reiterate that she needs to wear a very tight supportive bra, and a sports bra is also a very good idea. And she can apply ice if needed, if her milk does start to come in. But what we want to tell her is, just have no stimulation of the breast. So, just keep the sports bra on, the tight supportive bra on 24 hours a day for the first few days to try to suppress that milk from coming in. And then when they shower, they should have their back to the shower, not to let that hot water hit their chest, because that can also stimulate the milk to come in. And then, we no longer give the medication to dry up the milk, as I think I said before. So vaccinations, mom is checked with the first prenatal visit to see if she is rubella positive, which means she's rubella immune. She's immune to rubella. It is not given during pregnancy. So if a mother is rubella negative, her immunity is negative, then she can get that postpartum. We want to give that to her postpartum before she leaves, typically on the day she leaves. And she should not, it's important to tell her that she should not get pregnant for a month, which shouldn't be a problem, but just to reiterate that, you definitely don't want to get pregnant for a month. That's why timing that, giving that to her before, she leaves is a good idea, because she shouldn't have a problem getting pregnant for the first month. Also, if mom is Rh negative, she is going to receive Rogam. If the baby is Rh positive, right? We had a situation this past week at the hospital postpartum, and the mother was Rh negative, but the baby was also Rh negative. So she does not need to have that dose after delivery, because now we know that the baby is Rh negative. So she does not need Rogam, because there's no risk of her developing those antibodies. But if she is negative and the baby's positive, she will need Rogam within 72 hours. We will talk more about discharge instructions later in this unit. So here's just a little picture about the different complications that can occur postpartumly. Risk factors are greater in a mother who's had a cesarean delivery, or if she's had prolonged rupture of membranes, which you guys have all learned about, or if she's had a long, hard labor. If she's been catheterized, that increases her risk of a urinary tract infection, right? And the prolonged labor can increase her risk of hemorrhage. And there's some other risk factors, which we'll talk about. She can also develop mastitis. And I believe we already talked about that. I'm sorry, I should have refreshed myself. It's been a week, so I haven't can't remember. I think we've already talked about that. Yes, we have. So we talked about that. We want to make sure mom's breastfeeding correctly, that the baby's getting the good latch. So because that can, of course, if she gets any cracking of her nipples, that can be an entryway for bacteria to get into her breast. And unfortunately, she could possibly develop mastitis. Of course, upper respiratory tract infection can be a risk. The urinary tract infection we just talked about. Thrombophlebitis is a risk for all postpartum moms, but especially with our cesarean delivery moms. So cesarean section delivery moms. So we want to make sure that we're talking to the moms about getting up and moving and what kinds of signs and symptoms to look for. If she had a vaginal delivery, she could have a hematoma or abscess formation. That doesn't happen often, but it could happen in the vaginal perineal area. And then there's endometritis that can develop, an infection of the endometrium. And we'll talk more about that, and or perineal cellulitis, inflammation of the perineal area. It's good to maintain semi-Fowler's position to definitely localize that infection if they do have any of those infections, like endometritis or perineal cellulitis. Okay, let me just look at something really quick here. Oh, yes, okay. First off, we're going to talk about, we're going to talk about postpartum hemorrhage. There's two different types of postpartum hemorrhage. We've got the early postpartum hemorrhage and the late postpartum hemorrhage. It would be considered an early postpartum hemorrhage if it happens in the first 24 hours after birth. Sorry, my nose is going to itch. After greater than 24 hours, it would be considered a late postpartum hemorrhage. So greater than 24 hours after birth, but less than 6 weeks. So anytime after 24 hours to 6 weeks, it would be considered a late postpartum hemorrhage. What are we going to see? We're going to see, of course, excessive bright red bleeding, or a fundus that's very boggy. Now, if it's a firm fundus, we'll talk more about that on the next slide, so I won't get into that too much. It could be other bleeding areas. What also we're going to see is an increased pulse. So typically, as I said, mom's pulses run a little bit low. So if the pulse is increased, then we're going to suspect maybe a bleeding issue or pain. So we want to rule those out. And a decrease in blood pressure, but that would be a late sign. Could be a hematoma, which we'll talk about, or decreased level of consciousness. So, early hemorrhage. Biggest number one leading cause of postpartum hemorrhage is uterine atony. That's why we're massaging that fundus, making sure that it's nice and firm, checking that frequently right after delivery. So, you want to make sure that that's nice and firm. What can cause that is if the uterus was overdistended during pregnancy. So if the mom had multiple births, like twin pregnancies, or twin pregnancy, then she's at higher risk. If she had hydramnios, which is excess amniotic fluid, or a large baby, macrosomia is what we call our large babies, can cause that. Because that uterus has been stretched out, and it is a muscle, so it doesn't contract as vigorously as a uterus that has not been stretched out so much. So they are at risk for uterine atony, or the tone of the uterus being kind of flaccid. Oxytocin also in labor, if the moms were induced, that puts them at risk for hemorrhage. And that's because that uterus has been stimulated to contract and stimulated to contract. So it's kind of tired. And so that can be a risk factor for the mom having problems with her uterus contracting after delivery. Very long labor, again, that uterus is wore out, or dysfunctional labor. We'll talk about what's considered dysfunctional labor in a little bit. The more multiparity, so that would be moms that have had more than one baby. Again, that uterus has been stretched out. The more times that mom has had babies, the more times it's been stretched out. So it's just not contracting as well because of that. So they are at risk for uterine atony. If they receive mag sulfate, which relaxes the uterus, they can get that for preterm labor, just to reiterate, and they can also get that, or usually get that, for preeclampsia. But it has, even if it's for preeclampsia, it does have the side effect of relaxing that uterus. So they are at risk that medication's still in the system, and the uterus might still tend to be relaxed and not firm and contracted. It can be also that you won't notice it. It might not be as evident as quickly as you would think, because it could be a slow and steady rather than just a sudden and massive hemorrhage. What they're using now, where's my little book? I was going to write down the name, is what they can do is a uterine balloon. there's other things they can use, but that was kind of new. I want to grab my little book. Hang on just a second and tell you the name of that. But they can put a catheter up into the uterus and inflate it, and that helps. But that's kind of a last resort. We'll talk about the treatment, but it's called a Bakari, and we did see that being used in the hospital, or talk about it being used in the hospital when we were there last week. Okay. So that's uterine atony. Lacerations is what you're going to see with lacerations. So they can be of the cervix, they can be up in the vagina, or they can be, by the perineum. But what you're going to see is that their bleeding is heavy, but their uterus is firm. Okay, so we know it's not because of uterine atony, it's because there's a bleeding problem somewhere else. So it may be a laceration. Hematomas can be bleeding underneath the skin. And these occur because of birth trauma. Could be at the site of the episiotomy incision, or could be just like on the labia. We've seen that happen too. But it's due to, a lot of times it's because of a rapid delivery. These occur, we call that a precipitous delivery. And a precipitous delivery is they go into labor and they deliver, which you've probably already heard about, but just to reiterate, in less than 3 hours. So a very quick labor and delivery. A large baby also can cause a hematoma to form, a macrosomia baby or macrosomic baby. If the doctors had to use forceps or vacuum assisted delivery, that requires having more room and it's more trauma to that tender area, can cause a hematoma to occur. Lastly, and rarely, thank goodness, is an inversion of the uterus. This is where the uterus comes out of the pelvis. So it's a prolapse of the fundus, which is the top part of the uterus. So it kind of turns itself inside out, comes through the vagina, and it can be partial, where you might not even realize that, you don't see it on the outside. It's still in the vagina. Or it could be completely through the cervix and showing on the outside of the vagina. But basically, the uterus comes out and is turned inside out, which is not a good thing. Risks for this happening is if the placenta implanted high in the uterus, in the fundus part, that's where we want our uterus to clamp down really hard, the fundus. We're always feeling the fundus, right? So if the placenta implanted high up in the fundus, that could be a risk factor for this happening. Also, if moms have had a lot of babies, they're at risk for this happening. Or if there's excessive traction of the cord. If you were fortunate enough to see a delivery, which I was so thrilled, all of my students got to see some sort of delivery. So that's always my goal for the OB rotation. So we had a very good semester with seeing deliveries. But if, so the doctor will pull a little bit on that cord once the baby's delivered to get the placenta delivered. But, they got to be careful, because if they pull too vigorously, it could cause, this to happen. It could cause an inversion of the uterus. Also, if that uterus is just not clamping down well, so uterine atony can also cause an inversion or a prolapse of the uterus to occur. Okay. So those are all the reasons that an early hemorrhage can occur. Next, what would cause a late hemorrhage to occur? So after 24 hours, before the 6-week, or between 24 hours and the 6-week visit, subinvolution. Remember, we talked about that. Involution is where the uterus is coming down normally, as it should, 1 to 2 centimeters every day, right? And this is where the uterus is not returning to normal size, not going back into the pelvis as it should. So, for some reason, that placental site has not healed. Typically, the reason is that there are placental fragments still up there. So definitely you want to always check after delivery, look at your placenta, make sure all the parts are intact, that there's no missing parts, because it could cause them to end up with a late hemorrhage, late postpartum hemorrhage. So what they're going to see is the lochia is going to continue to be rubra color. Remember, we talked about like the 3rd day, it should be changing to the serosa. And so if they continue to have this rubra lochia longer than 2 weeks, that is not normal. And that could be an indication that the uterus is not going back into the pelvic area, not, getting smaller and moving down. And it could be because of having placental fragments up in the uterus. So they could also, because of that, develop endometritis, which is an infection of the uterus. And so they'll have signs of infection. They'll have a temperature. They'll have backache. They'll have foul odor. Their lochia will have a foul odor. That's why we want to teach them also to be on the lookout for that. And sometimes it's not even picked up until the 6-week visit. They just think, well, I'm just bleeding a little bit longer than I thought, so they don't really notice a problem. So a lot of times it's picked up then that, hey, the uterus has not gone back down into the pelvis as it should. And what they'll do is they'll try conservatively treating with methergin, and that is our oxytocic that is orally given to contract that uterus. Talked about looking at the placenta and looking to make sure there's no missing parts. If the subinvolution is due to placental fragments, what they can do is do an ultrasound, not x-ray, ultrasound. And what they will see is the fragments, the placental fragments still in the uterus. What they need to do then is to do a D&C, a dilation and curettage. So they're going to dilate the cervix, they're going to go up there and they're going to scrape the lining of the uterus to remove those fragments. And of course, if they've developed an infection in the uterus, and that's what's causing the uterus to not go back down, or because of the placental fragments, then they'd be treated with antibiotics. So I want you to definitely know the difference between an early and late, or the different reasons someone would have an early and someone would have a late postpartum hemorrhage. So we always want to avoid that again. So we're going to be doing fundal massages. We're going to gently massage. You don't want to be too vigorous, but you do want to support the uterus, right? We don't want to massage it to the point that we cause a uterine inversion, but that's the worst case scenario. But, just cup your hand below the uterus and then just gently massage. And it's really cool to feel how that uterus clamps right down if you need to do that. They may weigh pads if the flow is slow but steady. Definitely want to make sure that bladder is empty. And remember, we talked about that If we're palpating the fundus to see where it is and we notice that it's off to the right, deviated to the right and up higher than it should be, typically that is indication that their bladder is full. So they need to get up and empty their bladder. So it's a good thing to always, when's the last time you got up and urinated? Before we palpate their fundus, it's a good idea for them to get up and do that. And if it's been a while, have them do that. Definitely, we want to have them roll over so we can check their perineal area and also check underneath them. If you just check their pad to see how their bleeding is, they could be pooling underneath themselves. So you definitely want to roll them over if you're, well, you're going to roll them over anywhere because you're going to check the perineum. But, if you're concerned about their bleeding, roll them over also. Of course, you're going to monitor vital signs, look for signs of shock, decreased urine output, thirst, pallor, headache, orthostatic hypotension. But of course, we don't want it to get to that point. We want to catch it before then. So we'll use Methergin, but we could also, if they still have a IV, it could be they'll start, put Pitocin in their IV. And Hemabate is also another oxytoxic that they could use to stop the bleeding. Definitely, if there's any doubt or any, any suspicion that they are bleeding a little bit more than usual, their IV's kept in. And typically what they've done on postpartum is kept the saline lock at least in, for the first 12 hours or until they get the blood work back to make sure that their hemoglobin and hematocrit aren't too low. So if the bleeding is due to a laceration, they will suture those. If it's due to a hematoma, they may conservatively treat those with ice therapy, cold therapy. And if they feel like they need to go in, and they may need to ligate that bleeding vessel if it's a large problem hematoma. Or they may have to do an incision and drain of that hematoma. So definitely, if we have a mom who has gotten pain medication and just, doesn't get any relief, that we would definitely want to check out their perineum. So if they're, saying, gosh, my perineum, they might not use that word, probably won't, but that's what they're saying, that, I'm just not getting any relief. I'm just having a lot of pain in my perineal area. We would definitely want to roll them over and check that, but that is part of our assessment. Anyway, so we'll be doing that. The late postpartum infections can cause the uterus not to go down, which can cause a late postpartum hemorrhage. But the most common infection is the endometritis, which is the infection of the endometrium of the uterus. Then there's parametritis and peritonitis. And, the metritis is the pelvic area infection, and peritonitis, of course, is the perineal cavity. So what are we going to see? We're going to see high temperatures. We're going to see temperatures between 101 and 104, tachycardia, rapid heart rate, chills, anorexia, loss of appetite, nausea, fatigue, very lethargic, lots of pelvic pain. And if you palpate their uterus, it will feel tender. They'll say, ow, that hurts. It'll be tender. Or again, foul smelling lochia would also be an indication. Right. So the most significant risk factor for endometritis is C-section, having a C-section. So that they're at risk of that happening. They're higher risk. Also, extended labor with rupture of membranes. Remember, we want to get those moms delivered within 24 hours. So if they had a long, hard labor and their membranes were ruptured for a long time, and even it could be less than 24 hours, but that's always our goal to get them delivered. Um, they try to decrease the risk in C-section moms by giving them a prophylactic antibiotic 30 to 60 minutes before they do the incision, or sometimes, right before they do the incision to decrease that risk. Okay. So, the pelvic parametritis infection involves the connective tissue of the broad ligament, and in severe cases, the connective tissue of the pelvic structures. With our peritonitis, the infection is spread through the circulatory system and the lymphatic system and spread to the perineum, and now involves the perineal cavity. They become very acutely ill with severe pain, lots of anxiety, high temperature, rapid and shallow respirations, tachycardia, excessive thirst, and abdominal distension, nausea, and vomiting. So they have all those signs of an acute infection. So that's pretty serious. Then we can also have wound infections, and they can be infections of the perineal area or the C-section incision. And, miraculously, most moms do not have problems with infections of their perineal. It's kind of surprising. More commonly are the cesarean section incisions. And of course, we want to be assessing for any redness, any edema, any warmth, any tenderness at that area. What we would see if they came back in. This typically is going to happen after moms go home. They come back in, and this is our findings. They could have where the incisions opened a little bit and having serous drainage or purulent drainage coming out of the incision. And it could be from the perineum episiotomy area, or the laceration site can also have, redness, warmth, swelling, and tenderness and drainage. So of course, if, the wound opens, it's going to be separated. Moms are going to be having a temperature and pain in the area. If the incision does open, typically that will be left open to heal from the inside out. So with secondary intention, we call that. And then if necessary, it will be closed after the infection has resolved. So you never want to close it back up with an infection still in there, right? Because it could spread to the perineum and other areas, perineal cavity, or other areas. So you want to make sure all that infection comes out. So typically we leave it open to heal from the inside out. So if the wound is open, the mom may have to have her wound packed, and this may be done 2 to 3 times a day. She will be on antibiotics. That could be cephalosporins, penicillin, vancomycin, clindamycin, ampicillin. They're going to test for what the infection is, what the bacteria is. So typically, they may not, but they may want to culture that, especially if there's drainage coming out. And I did not mention this, but streptococcal, anaerobic, and Staph aureus are the most common organisms affecting the postpartum mom in wound infections or infections postpartum. Definitely, we're going to be washing our hands frequently, changing linens. We're going to, instruct mom to definitely wash her hands frequently. Pain relief is a definite priority, especially, if she has a lot of pain with dressing changes. We want to time it so her medication has kicked in during the dressing change. So give her pain medication before that. Using aseptic technique, a wound like this is not going to require sterile technique, but definitely we want to use the cleanest technique we can in doing these dressing changes. We want to encourage her definitely to increase her protein for wound healing and vitamin C to help with wound healing. Her pelvis needs to rest, so pelvic rest. So no tampons, no douches, no intercourse during this time of management. Okay, and of course, we're doing our evaluation of the episiotomy and the incision with our RITA acronym. Another type of infection that can occur is urinary tract infection or cystitis, and we've kind of talked about this. What are you going to see? It may be that they're not emptying their bladder completely, so you're going to see that the bladder is distended, or they might not be able to void. So overdistension could be that they're voiding, but they're not completely voiding, or totally inability to void, may have a backache and fever. Risk factors, include the normal postpartum diuresis, as we talked about, increases that bladder filling. So it's filling rapidly, and they need to make sure that they're voiding frequently. Remember, every 2 to 4 hours. They also can hold a lot of urine. So, stagnant urine in the bladder can be a risk factor. Postpartumly, they have an increased bladder capacity. And, if they've had vaginal delivery, it could be from, the trauma to that area, that they kind of don't have that sensation, as we've hit on before, that they need to go to the bathroom, urinate. So again, just reminding them to void every 2 hours can be helpful. If they've had a catheterization, in and out, even catheterization, because they had an epidural and they we needed to empty their bladder. Definitely anytime we do a catheterization, they're at higher risk for an infection to have occurred. So we definitely want to make sure we are using sterile technique with our catheterizations. Excuse me. And you probably already know this, but the most common bacteria in cystitis is, of course, E. coli. That comes from the rectal area. So we want to make sure our moms know to, wipe from front to back, use that peri bottle, pat dry from front to back, change that pad frequently, all those good things to avoid any infections. So again, frequent management is frequent voiding every 2 to 4 hours, remind them. And if we can minimize that swelling in the perineum, that's also going to help them feel that urge to void. If they're not able to void, we may have to straight catheterize them. But of course, we're going to use extreme sterile technique. In a urine culture, if there is greater than 100,000 bacterial concentration or colonies of bacteria, that is indicative of an infection. Typical medications we use are sulfa medications, Bactrim or Septra. Ampicillin also can be used. And we may be able to also giving them pyridium. And that, of course, we've got to warn them, turns their urine orange. And that helps definitely relieve the discomfort and pain or spasms in the bladder. We want to let them know that they should actually avoid soft drinks, that cranberry, plum, apricot, and prune juice are good because they acidify the urine, which is good. Definitely, we want to have them drinking lots of water, flush out that infection, and talk to them about, in the future you really want to wear cotton crotch underwear. Is always a good recommendation to avoid urinary tract infections. Okay. Okay. All right. What can occur also postpartumly is mastitis, and this is an infection of the breast. Typically happens in our lactating moms. Usually not until they get home, of course. Between 2 and 8 weeks postpartum is when it typically happens. But it also can happen anytime that the mom is not nursing as frequently. She decreases the nursing frequency. It can be a local inflammation, or it can lead to an abscess and, heaven forbid, septicemia. We definitely want to catch it before then. But what kind of symptoms is mom going to have? She's going to have flu-like symptoms, chills, fever, malaise, local breast tenderness, typically only in one breast, thank goodness, redness, swelling. It could be axillary swelling also in the axilla. So, inflammatory edema and engorgement of the breast obstruct the blood flow, flow of milk. Usually because of an infected nipple, it gets in through a crack in the nipple and goes into the ductal area. And if we can treat this promptly, we avoid those other problems of an abscess occurring or septicemia, heaven forbid. And the best treatment is to empty that breast. So typically breastfeeding is continued. It does not hurt the baby at all. Mom will be on an antibiotic, or if it's a fungal infection, she will be treated, and also baby will be treated. And how you can tell if it's a fungal infection, Candida albicans, is if you look in the mouth of the baby, they will have a white film on their tongue. So we want to watch for that. And we call that thrush in the baby's mouth. So the baby will be treated for that, and mom will be treated for that. But if it's due to a bacteria, mom will be put on an antibiotic and encouraged to continue to breastfeed if it's not too uncomfortable. The main thing is you want to get that milk out because it typically occurs because of milk being stagnant in the breast. Okay, so what they need to do is either pump if they are not able to breastfeed. Of course, babies empty the breast best. So if she can continue to breastfeed, that's encouraged and safe for the baby to continue to breastfeed. If it's so uncomfortable, then she can pump. But we need to make sure that we get that milk out. And so that is one of the treatments for that. And I got to my next slide. So again, frequent emptying is what we need to do. So, breastfeeding every 2 to 3 hours, or, pumping every 2 to 3 hours, switch breasts, each time. It might be more comfortable for the mom to start with the breast that's not affected and then go to the other breast that has the mastitis. Milk, of course, is a favorable medium for bacteria, and the stasis of the milk is the other factor there. So definitely we want to get that milk out of the breast. She's going to be on bed rest, and of course encouraged to increase her fluid intake. Have a supportive bra. Warm, moist compresses or ice packs. So warm, moist compresses before she breastfeeds helps with that letdown and is comforting. And then afterwards, she can, of course, put ice packs on there, which is also helps with the pain. Typically, they're on cephalosporins, antibiotic for that. Um, Analgesics, NSAIDs, our ibuprofen work really well at treating the fever and the inflammation that's involved. If it's a candida albicans infection, a yeast infection, a fungal infection, mom can be put on diflucan, and it's okay for the baby. So that might be a form of treatment for that. We want to make sure that, we reiterate, we don't ever want our moms that are breastfeeding to use soap on their nipples because it can be drying. They should only use warm water, but we just want to reiterate not to use any soap on the nipples and allow them to air dry. And, really, the best treatment for sore or cracked nipples is actually mom's milk. So she can express a little bit of breast milk at the end of the feeding and rub that on her nipple. That can help with the soreness and, healing of the nipple, and then have her air dry. So that's a good treatment to recommend also. And of course, she needs to, definitely practice good hand washing. Of course, we'll also, as we always do, practice good hand washing, but definitely moms need to make sure they don't touch their breast unless they've washed their hands. Okay. All right. As I said, thromboembolic disease is a risk factor in postpartum moms. They've got, it can be a superficial venous thrombosis, or it can actually be a deep vein thrombosis. What we're going to see is tenderness. We do the Homan sign, but they're going to have tenderness in their leg. Their Homan sign is going to be what we call positive. So when we bend back their foot, they're going to say, ow. If we look and compare one leg to the other, we're going to see a noticeable difference in, they're going to have more swelling, redness, warmth in the affected leg. They may run a low-grade fever and decrease pedal pulses. So we do want to check those also. Why this happens is, in pregnancy, moms have a lot of clotting factors, and these are all to compensate for after delivery, to keep her from hemorrhaging. But then after she delivers, they can be a risk factor for developing thrombophlebitis. So definitely, there can be stasis of blood flow in the legs. So we want to get the moms up, we want to get them moving, and the stasis in the lower veins in the legs are due to that large uterus, which is still a little bit enlarged, putting pressure on the lower veins and decreasing the venous return. So we want to get them up moving pretty quickly, right? We want to get our postpartum up as soon as they can feel their legs, getting them up to the bathroom and having them continue to do that. And with our C-sections, by 12 hours, we want to get them up out of bed. And don't forget, there's always the risk of pulmonary embolism. Anytime there's a blood clot in the legs, it can move to the lungs. And this is a more serious, definitely serious complication of having a DVT. So make sure that you're looking for signs that the mother may be having the blood clot has moved to the lung, shortness of breath, also a temperature, all the signs of pulmonary embolism. Risk factors are higher in our C-section. Any moms that have had a history, of course, are at higher risk. If they've ever had a history of deep vein or superficial venous thrombosis, they're at higher risk. Or if our moms have varicosities, if they have a lot of varicose veins in their legs, they're at a higher risk. Obesity is a higher risk. Maternal age over 35 puts them at higher risk. Multiparity, moms that have had more than one baby, and of course, smoking. And just to add, trauma to the extremity can also be a risk factor. But hopefully they're not going to have trauma to their extremity. But it could be if, maybe with pushing, they, bumped on the stirrup, something like that. So those are all folks that we need to be extra, cautious that this can develop in them. So just a side note, if the patient has been on antibiotics for endometritis without relief of symptoms, it could actually, they're still having a lot of discomfort in the pelvic area. It could actually be a DVT in the pelvic cavity. So, that's always a thought if they're just not getting any relief and they've been on antibiotics long enough to they should be feeling better because of that. Okay, so we'll go over management and then we'll take a break. All right, so again, early ambulation, it's a must. Anticoagulation therapy, they'll be on heparin, switched over to Coumadin, or they'll be on Coumadin until the INR is at the therapeutic level, typically 2 to 3. And then the heparin will be discontinued. And typically they're going to stay on that Coumadin for 3 months if they develop this. It's diagnosed with a Doppler. We're going to have them on bed rest and elevating that affected extremity. Elastic stockings, TED hose on, heat is good. I'm not seeing that done as much, but warm, moist heat used to be the treatment of choice. One of the treatments that we routinely did was put moist heat on that, put a warm towel over the area and then put a heating pad over that. We want to make sure that they're avoiding the 3 Gs, which are our ginkgo, garlic, and ginger. Because these prolong the prothrombin time, increase the prothrombin time. So it takes longer for them to clot. So it's kind of, messing with what we're trying to do. So we don't want that to kind of throw a wrench in things. Also, we want them to be aware of foods with vitamin K because that can cause them to clot. Like broccoli, leafy green spinach, they can eat them, but they need to consistently eat them and not in large amounts because that can cause clotting problems. Oh, I was going to add that actually at the hospital, they've started implementing giving moms heparin or Lovenox, which is, a heparin equivalent, pretty much so. If they had a C-section or if they were obese, there's certain criteria. If they met, then they would be put on heparin for, I'm not sure, a couple days or so. So that's kind of a new protocol at the hospital, just to avoid this from happening. Okay, so I've got about 11. How about you guys come back at 10 after and we'll pick up with postpartum depression. Does anybody have any questions for me at the moment? No? Okay, well, if you think of any, let's see, have a couple in the chat. Let's see. Yes, I will give you a blueprint for the test. Yes, you can still breastfeed if you have a bacterial infection. So mastitis, if it's also in the breast, mastitis, I'm sorry, if any kind of infection, you can still. Typically, they're not going to put you on an antibiotic that is going to impede you from being able to breastfeed. So yes, you can still breastfeed for any type of antibiotic that you're on, with any type of antibiotic you're on. Okay. All right. Well, feel free to send me a chat question, and I will check those when we stop for a break. So I'm going to put my recorder on pause. Record. Oh crap! Hit the wrong button. Okay. Well, now we're going to have two recordings. Sorry about that. I hit the wrong button. We'll figure it out. Okay. Let me share my screen. And okay. Postpartum depression. So, of course, postpartum blues, or not of course, but just so you know, postpartum blues are just feeling down. And this happens within the first few days postpartumly. Sorry, I'm showing my face. Hang on. Let me stop for a second. There you go. Okay. Okay, here we go. So postpartum blues are when just feeling a little down. You have happy times, but then for some reason you'll just stop crying, or you'll just start crying for no reason. And that is really normal. There's a lot of hormone fluctuations after you deliver, and that can cause you, and you're tired, and this might be brand new baby for you, first time, and it's just like you just feel kind of overwhelmed. And that is normal. And that usually disappears within a week, where you have the, crying spells and, just weepy for no reason. I remember that myself, thinking, well, I'm so happy. Why am I crying? So, but that is normal. Postpartum depression is a whole different ballgame. So this is where the mom has really intense, pervasive sadness, very low moods or mood swings, lots of fears, lots of anxiety, maybe anger, might even be despondent, maybe irritable, maybe, leading to uncontrollable sobbing. And this is also called peripartum major mood episodes. And it usually begins about 4 weeks postpartum and only occurs in about 10 to 20% of all postpartum moms. What the risk factors are first-time moms, primiparity, ambivalence, mixed feelings about the pregnancy, whether they, wanted it, or not, wanted the baby. Or if they have any history of major depressive disorder, that is a risk factor of developing postpartum depression also. Could be also people are higher risk or moms that are higher risk that they don't have a real good support system, or, they're not confident, they're low self-esteem. So those are some of the risk factors for this developing. There we go. Okay. So we manage this with, they get psychotherapy, speak with a counselor, and are put on antidepressants and get a lot of support. So individual or group psychotherapy. SSRIs, are selective serotonin reuptake inhibitors, are good antidepressants to use, or tricyclic antidepressants. Those are both safe with breastfeeding. Getting them help can also be helpful. the big concern with these moms is the safety of the baby. So, we hate to do that, or, whoever hates to do that, but it may involve, taking the child from the home until she can get over this. But hopefully it won't lead to that. There's always a risk of psychosis with this, which definitely could lead to her harming the baby. So that's our biggest concern with postpartum depression. Okay, so that ends that set of slides. So let me stop sharing here. Anybody have any questions? Okay, so we will go to the second set of slides. Okay, let me go here. Okay, let me pull it up again. There we go. It's good to hear me talk to myself. No. All right, share screen. And here we go. Okay, now we're good. Okay, so part 2. So here's our so we talked about mom. Now we're going to talk about the newborn. And this is chapter 23. This little picture just talks about all the things involved in the newborn. Of course, the APGAR score. We'll talk about that. And, mentions, a lot of different things, the acrocyanosis, the little blueness of the hands and feet, which is normal. Heart rate, well, we say 110 to 160, but about in that range. We're going to talk about the different ways baby can lose heat, which is very, very important to consider because of what can happen. Cold stress is very dangerous for the baby. So we'll talk about that. Here it mentions the average length and the average weight. We'll talk about molding. We'll talk about caput succedaneum, the swelling on the head, fontanelles, excuse me, always looking to make sure they're not bulging or sunken. We'll talk about all of those. So this is kind of just a nice little picture, and talks about within the first minute all the things that should be occurring. Make sure I'm pinned. No, I am pinned. Good. Okay. All right. All right. So first we're going to talk about okay, I'm sorry, I'm getting a text coming through on my watch. APGAR scoring. So that is done at 1 minute and 5 minutes after birth. And what are we looking for? We're looking at heart rate, and we want that heart rate to be greater than 100. So they get a total score of 10. It's possible to get a total score of 10. Does that happen at 1 minute? Rarely. Okay. And typically what is marked off is skin color. So for their body to be totally pink, they would get a 2. Well, that doesn't happen very often. Typically, the peripheral circulation is a little sluggish in the beginning, so their extremities are blue. So they typically do get 1 off for color. If they're crying vigorously, their heart rate is definitely up, but the nurses will listen to that. We want it greater than 100, and they get a 2 for heart rate. Respiratory effort. So if they are vigorously crying, we know they've got good respiratory effort. We want to see their extremities flexed very tightly. Okay, so their arms and their legs should be flexed to get a 2. So also, if you get a scenario about APGAR, if they are crying vigorously, they get a 2 for respiratory effort, and they get a 2 for reflex irritability. Okay. So crying is also under reflex irritability. And then, as I said, skin color is typically what they get marked off on. There's not too many babies that are totally pink at 1 minute. So a 9 APGAR is a wonderful APGAR. Okay. But it evaluates the physical condition of the newborn at birth. And again, done at 1 and 5 minutes, and they receive a score from 0 to 10. Let's see. Acrocyanosis, the blueness of the hands and feet, is common in newborns. So again, they will not get a 2 for that, for color. 7 to 10 is considered good. 8 to 10 is better, but 7 to 10 is considered good with only minimal effort needed to stimulate them. So if we dry them off, and maybe at 1 minute, they're not quite as vigorous with their cry. If they're slow to cry, they'll be marked off 1. So, it could be that they're a 7 at 1 minute. But if we're able to give them a little oxygen, and it's, coming up, their color's improving, then we should be good to go. Anything less than 7 is considered needing resuscitative measures. Okay. So we want it to be 7 to 10 at least. So now what they're doing more commonly is PEEP, which is positive and expiratory pressure. So they put the mask on, and it actually kind of like CPAP. It just expands the lungs, opens the lungs to allow that increased volume of oxygen to get into the lungs at the end of expiration, or remain, in the opens up the lungs, allows increased volume of the gas remaining in the lungs at the end of expiration. So it kind of just opens up the lungs a little bit. Okay, so they might just give them PEEP with a little oxygen. Okay. So this is a nice little table about the initial newborn evaluation. So we want our respirations to be between 30 and 60. Irregular is fine. That's why we count them for a full minute. But we do not want to see that baby retracting, pulling in, okay, or grunting, making a grunting sound. Those are sounds of respiratory depression or distress, excuse me. So we don't want to see those. We want the heart rate to be 120 to 160 and somewhat, maybe a little irregular, and that's okay. Skin temperature is very important. We want it to be at least 98.8. Okay. I like 98, it's 97.8. Sorry. I like it to be at least 98, but 97.8 is acceptable. We accept that, we want the body to be pink, and we accept, blue extremities is okay until that peripheral circulation can get up to where it needs to be. We want to look at the umbilical cord, make sure there's 2 arteries and 1 vein, and gestation needs to be 38 to 42 weeks. So 2 weeks early or 2 weeks late to remain with the parents. Less than that, is debatable by the nurse, neonatal nurse practitioner, whoever's there for the delivery. What we want to see is for a full term baby, the sole creases on the bottom of the foot should cover the foot. That tells us our baby is full term. And, generally we're going to only see a small amount of vernix, which is that white coating that babies have on them at the time of delivery. For our full term babies, there should not be a lot of it. If there's a lot of vernix, then our baby is more premature than full term. But you may see it in the creases like the axilla, the groin. You may see lanugo, which is that fine downery or thin, very soft hair. You may see some of that on the upper back, but if we see a lot of that, that can indicate also prematurity. The ears, the pinna of the ears should bounce back. So there should be enough cartilage that if we bend the ear forward, it'll bounce back. It won't, in preemies, it will just kind of stick to the face. So that's a good indication. In our males, the testicles should be descended. It should be able to palpate them in the upper or lower part of the scrotum. In our females, the genitals, the labia majora is larger and red, is normal because of mom's hormones. And the clitoris should be nearly covered. All right. So in the following situations, the newborn should be stabilized rather than remaining with the parents. So if the APGAR is less than 8, well, it says less than 8 here. At 1 minute, and less than 9 at 5 minutes, or the baby requires resuscitative measures other than whiffs of oxygen. If the respirations are below 30 or above 60 with retractions or grunting. We're going to talk about the reactive phase right after delivery in just a little bit. And so hold that thought. But so the respirations may be a little bit higher than that, because that's kind of normal during that first reactive period. But if they're not having any signs of distress, like retractions or grunting, then they're probably okay. Apical pulse below 120 right after delivery. If they're in a deep sleep, they can go lower than that. But we want our babies at birth to be crying vigorously, lusty. And so it should not be, the heart rate should not be below 120 or above 160 with marked irregularities. Again, that 160 might be a little bit higher than that in the first 30 minutes of life. Again, skin temperature, we want at least 97.8. So if it's below that, that would be, we want to leave the baby on the warmer and get them warmed up. If the skin color is pale blue, not a good, or circummoral paler. Okay, so if they're really pale around their mouth, that's concerning. Now, circummoral cyanosis, little blueness around the mouth, is a normal finding in our newborns, but we don't want it to be pale around the mouth. And of course, we don't want them to have a pale blue color. We want them pink. Babies that are less than 38 weeks or more than 42 weeks gestation need to be stabilized typically. Or if they're very small or very large for gestational age, we have to, check them out. They'll be on the blood sugar protocols, so we'd want to be checking a blood sugar fairly quickly. And of course, if there's any babies with any congenital anomalies like meningomyelocele or spina bifida, which is the open area in the lower back, they would have to be taken to the intensive care nursery. And those are also called neural tube defects. But our babies do go through 2 active phases or periods of reactivity. where their pulse may be as high as 160, or I'm sorry, 160 to 180. And their respirations may be as high as 60 to 80. You may initially hear some crackles in the lungs until those all the fluid, they've worked all that fluid out of their lungs. And they can have periods of apnea, but up to 20 seconds, but not more than 20 seconds. Okay, so no more than 20-second periods of apnea. So the first period of reactivity is the first 30 minutes. And this is right after birth. It is the best time to initiate breastfeeding. Okay, so typically we're taking those babies over, we're drying them off, they're crying well, checking them out, doing their APGARs, and then we're getting back over to mom to initiate breastfeeding because they're alert. And this is a great time to do this. They have a strong suck typically at this point. But what we're going to see is the respirations are going to be up. They're going to be higher, 60 to 80. And the pulse is also going to be up, 160 to 180. And that's okay as long as we don't see any signs of respiratory distress, which would be our grunting, our flaring of the nares, our retractions. Okay. So those are acceptable during this period. About after 30 minutes, they go into a deep sleep. They go into the sleep phase. And during this time, you may see, if you would listen to their heart, you would listen and hear it lower. It could be as low as 100 to 120. So again, the infant's alert and active, and then sleeps for a period of time. And this period of time where they go into this deep, that's why we want to initiate breastfeeding in those first 30 minutes, because then they go into this sleep period. And they're very difficult to wake up, and they're very difficult to, of course, wake up to breastfeed. So we want to make sure that we initiate that breastfeeding in the first 30 minutes. Because once they go into the sleep phase, they're very difficult to wake up and may sleep for 2 to 4 hours. After that sleep period, they wake up again and they have another period of reactivity, and that lasts about 4 to 6 hours, where the heart rate and the respiratory rate increase. And they may have periods of apnea, and we want to monitor these babies to make sure that they're not having any color changes with their periods of apnea, and that they're not lasting longer than 20 seconds. Okay. And typically the meconium is passed in the second phase. Of course, it can happen at delivery too, but typically it's passed at during the second phase of reactivity. Okay. All right. So at birth, the infant does that gasp and then cry. And so surfactant or respirations may be a little shallow and irregular, but again, we're looking for any signs of distress, nasal flaring, retractions, grunting. With respirations less than 30 is a concern, or greater than 60 when the baby isn't crying. Okay. Surfactant secretion occurs with those first breaths. And what surfactant is it's a coating over the alveoli, and it keeps the lungs from sticking together when the baby exhales. So it's very important. It's a lubricant that babies need in their lungs. And it's not produced in real preemie babies. It's produced after 28 weeks and actually peaks at 35 weeks. So we really don't want our babies to be born before 35 weeks because of that. During fetal development, the lungs are filled with what we call fetal lung fluid. And that just helps inflate the lungs so they can fully grow to the needed growth that's needed. But what happens when labor starts is catecholamines and other hormones are released, and this stimulates the fetal pulmonary epithelial cells to begin to reabsorb that fluid from the alveoli space. Okay, so this lung fluid starts to be reabsorbed. Okay, at birth, when that baby comes out of the womb, which has been dark, to a bright, cold delivery room, this stimulates the initiation of breathing. The newborn's first breaths, where they take in air, initiates a sequence of events that empty the airways of fluid, okay, and establishes lung function and volume. And this causes the fetal circulation also to convert to neonatal circulation. So it's switching over. So many things, so many important things happen. So that's why we, want to see that baby take that first breath and start crying, okay? Because all those things need to happen. So if we have a baby born in fetal distress, these things don't occur, and this is when we have problems. So what happens with that first breath? It causes a high negative pressure, driving the fluid from the lungs and fill the alveoli with air. So we need that negative pressure to occur with that first breath, and it just pushes all that fluid out, and so the air can come into the alveoli. So the best assistance during this time that we can do is to remove the fluid from the nose and mouth, the mouth first. We're going to suction the mouth first, squeeze that little bulb syringe and let go and squeeze it out and let go and squeeze it out, and our nose also, or their nose also, but mouth first. So that's what we want all to happen in that first minute of life. With the lung expanding, the surfactant secretion starts or is secreted and lowers that surface tension, allowing those alveoli to stay open with expiration. So it's really a cool sequence of events that occurs with that first respiration, that first breathing in and gasp. So this is a little graph on what happens. So the baby takes its first breath, which increases the oxygen level. And so there's been a lot of resistance in the lungs. So that with that first breath and increase in oxygen, that pulmonary resistance, vascular resistance decreases, allowing that oxygen and blood flow to go into the lungs, which it hasn't needed, right, up until this point. So again, increased pulmonary blood flow occurs with that. Increased pressure in the left atrium. So we've got the opening, the foramen ovale, okay? And so that extra pressure, increased pressure in the lungs causes the pressure in the left atrium, and that it causes the closure of the foramen ovale. Also, that increased oxygen level increases systemic vascular resistance, which increases the systemic venous return. And so this with the which causes the stopping of the umbilical venous return and the closure of the ductus venosus. Okay. So with the increased pressure in the left atrium, there is a decreased pressure in the right atrium. Okay. Also, with the increased systemic vascular resistance, we have an increased systemic resistance greater than the pulmonary, and this closes the ductus arteriosus. Pulmonary resistance that is less than the systemic causes the left to right shunt to close also. So all these things happen with that first breath, which is really amazing. So the first breath reduces the pulmonary vascular resistance to the pulmonary blood flow. So there's more blood flow. This dilates the pulmonary vessels, so there is less resistance when there's increase in perfusion to the rest of the body. The increased systemic resistance. This causes, again, the ductus arteriosus to close, so that left to right shunting no longer occurs, and then pulmonary resistance is less than systemic. Okay. So their foramen ovale closes in about 1 to 2 hours. The ductus arteriosus, initially it closes, but tightly closes in 15 hours. And the umbilical arteries, vein, and ductus venosus close immediately once that cord is clamped. Cuts those off. Okay. So it's a wonderful, exciting phenomenon that occurs with the first breath. So if a baby is in a deep sleep, their heart rates can actually fall down to 80 to 100 and to 110 to 160 while awake. So there are periods where they're in such a deep sleep that it really falls down low. As long as they're not having any signs of distress, they're okay. So we definitely get apical pulses on all babies, and we listen for a full minute. And you might in the first hours of life, because those shunts have not totally closed, those openings in the infant circular or the fetal circulation have not totally closed. So you may hear may hear a murmur, okay? But 90% of the murmurs are temporary and not associated with anomalies. But definitely you want to pass that on if you would pick up on a murmur, and they will follow up on that. But look, fortunately, they're just temporary, and in 90% of the babies, they're benign. They're not a problem. They're not a cardiac problem, which is great. Okay. Next, looking at their normal blood values. They typically have a higher hemoglobin and hematocrit initially, and this is due to the plasma from the intravascular to the extravascular space occurs. So the fluid in the blood is pushed out to the extravascular space. Then what happens, the fetal hemoglobin decreases about 3% per week and less than 5 to 8% by 6 months of age. The initial decline in the hemoglobin creates what's called a physiologic anemia. However, the newborns are not really, it's not a problem for them, and they tolerate it really well without any difficulties. But initially, it is quite high, 14 to 20. Leukocytes are elevated, their white blood cells are elevated, as you can see. 10 to 30,000 are not abnormal in our newborns. Of course, that's elevated. As we talked about moms being elevated, babies are also elevated quite a bit. And that's normal. And they feel like this is due to, the theory is that it's due to the stress of birth has caused their white count to go up. So with sepsis, what we're going to see in the newborn is actually a low white count. So the white count is wiped out. So we're not concerned about the high white count, but we are concerned about a low white count and neutrophils. So if we see that, we are suspicious that there might be an infection. Clotting factors are decreased because the newborn cannot synthesize clotting factors in the liver due to the lack of vitamin K. So that's why we give the babies aquamaphytin or vitamin K. And the reason they lack being able to synthesize the clotting factors is because they don't have the intestinal flora when they're born, and that's needed to make vitamin K. And that's why we give them aquamaphytin, to just get them through that transition period where they're introduced to our environment, and then they start having bacteria in their bowel. But they, of course, don't have that at delivery. So we give them aquamaphytin, and that's to prevent them from having any hemorrhagic disease of the newborn. Glucose appears to be low. If you look at the glucose level, 45 to 96. In an adult, that would be alarming. But that's normal in a newborn initially. We want our full-term newborns to have a blood sugar greater than 45, okay? So full-term newborns, we want it to be greater than 45. And if it's not, they have protocols in place to treat hypoglycemia. And we'll talk more about hypoglycemia in a little bit later, okay? All right, in the newborn. All right. So next we're going to talk about thermoregulation. Very, very important. Of course, establishing respiration is first priority with our babies. The next is thermoregulation. Very important. And thermoregulation is the balance between heat loss and heat production. Babies, rapid heat loss is a concern and can be harmful to our babies, causing them cold stress. And we'll talk more about that. They don't have the ability to shiver. Okay. So shivering helps warm us up. When we get shivered, our body warms ourselves up. Okay. But babies don't have that. What they do have is what's called brown fat. And that's very unique in the newborn. And that regulates thermogenesis, or the production of heat. So metabolism, breaking down that brown fat, helps heat the body, or help leads to heat production. And it's located in different spots. It's located in the intrascapular region, the axilla, as well as it deep in the thoracic inlet and vertebral column, and around the kidneys. So the less mature a baby is, the less brown fat they're going to have. So of course, less mature babies are going to have more problems keeping their temperature up because they don't have this wonderful brown fat that they need to help heat them up. So what we want to look at is how our babies lose heat, okay? The first one is convection, okay? Convection is the flow of heat from the body to the cooler air current. So we want to make sure our babies are not under a vent that's blowing cold air on them, okay? A lot of times our moms are kind of hot after delivery, but we have to tell our moms, you got to keep it warmer in here for the baby, okay? Because they're going to lose heat through that air current, all right? So definitely we want to make sure those babies are not underneath an air vent because they can lose heat through convection. Radiation is where the baby will lose heat to a colder environment. So if the baby is close to a window in the winter, they will actually lose heat because their heat will radiate to that cold window. So we want to make sure our babies are not close to a cold window in the winter, okay, in mom's room, because they can lose heat through radiation. So that's where they lose body surface. Their body surface heat goes to that cooler solid surface that they're not in direct contact with. Okay. Evaporation. Loss of heat that occurs when a liquid is converted to a vapor. That's why we need to get those babies, they're coming out wet. We need to dry them off. You see us drying them off. First thing we do is to prevent them losing heat through evaporation. So we want to dry them off really good. Conduction is where that baby loses heat when they come into direct contact with a cold surface. So in the delivery rooms, you'll notice, when it's getting close to delivery time, the nurses will turn on the radiant warmers so that radiant warmer bed will be warming up. So when we put that baby on that bed, it'll be a warm surface, not a cold surface, and cause them to be cooled down from that. So those are the 4 different ways babies, and all of us, but babies especially, can lose heat. And we want to be aware of those. Okay. So the goal is to keep our babies in a neutral thermal environment, okay? Because their insulation is less than ours, they're very susceptible to losing heat. But if we keep them in a neutral thermal environment is where oxygen consumption and metabolism are very minimal. Okay. So we don't want them to, using all their oxygen up and speeding their metabolism up, trying to get themselves warmed up. Okay. So we want that neutral thermal environment and to maintain that internal temperature. Also, oxygen consumption can increase, which we don't want them to be, struggling to cool themselves down either. So we want to make sure our babies aren't too hot. Okay. So, we just want a neutral thermal environment, keeps that baby about 98 degrees, 97.8, right? Not too cold, not too hot, because either way, that's going to cause that baby to have to work hard to either cool themselves down or warm themselves up, more importantly. But, having it too hot can also cause problems. The way babies keep warm is they keep flexed, okay? You'll notice if you've seen when we get to talking about our preemies, they tend to they don't have that flexion, okay? So they're, of course, at more risk from losing temperature. So that's a protective mechanism by keeping them, if we get cold, we roll up in a little fetal position, ball, and that helps warm us up. Because flexion, of course, decreases the surface area exposed to the environment. So that keeps them warm. They do have a large body surface to weight ratio. So that puts them at risk. So again, our concerns are we don't want that baby to get cold and we don't want them to get too hot. Cold stress or hypothermia. Signs and symptoms of cold stress are that baby's moving around, trying to warm themselves up. The respirations will increase. Decreased skin temperature. So, that's why we do the axillary temperatures on babies to make sure they're warm enough. We want them at least 97.8, 98. Decreased peripheral perfusion, you'll notice. Hypoglycemia, and we'll talk about signs and symptoms of hypoglycemia. Big one, tremors, okay? They do have the startle, but tremors, okay? If you notice that a baby is cold, you want to immediately check, or if a baby gets cold, body skin temperature is cold, and they're tremorous, you want to definitely check that blood sugar, because they're, been burning their blood sugar trying to get themselves all warmed up. And it can possibly lead to also metabolic acidosis. So their initial response is vasoconstriction so that helps us, to pick up on with the skin temperature. And like I said, if it's decreased, check for hypoglycemia. And because of the cold stress, their blood sugar may be less than 45. And so what you're going to see, again, is the tremors. They may be irritable, lethargic, periods of apnea greater than 20 seconds, or actually have seizures. And we certainly don't want that to happen. Okay. So when we look at their liver system, their hepatic system. So the fetal liver stores iron in utero, and at birth, the infant has iron stores sufficient for about 5 months. Glucose is used for energy, and as those stores are depleted, metabolism changes over to fat metabolism from carbohydrates. Energy can be derived from fat and protein as well as carbohydrates. Bilirubin is the result of phagocytosis of RBCs, so the breakdown of the RBCs. So babies do this more rapidly than we do, and so that causes them to have a higher bilirubin. And so the bilirubin is the yellow lipid soluble pigment, and we will see that in the skin. When we look at bilirubin, there's 2 types. There's unconjugated form, indirect bilirubin, and there's conjugated, direct bilirubin. Indirect cannot be excreted. Direct can, or the conjugated. And so we want it to switch over to the conjugated so it can be excreted as bile. So conjugation is the changing of bilirubin into an excretable form, okay? It's the conversion of that yellow lipid soluble pigment, the unconjugated, indirect, into the water soluble pigment, excretable, direct, or conjugated. Unconjugated form or indirect bilirubin isn't excretable. They can't excrete it, get rid of it. It is bound to albumin. It is then transferred into the liver, which determines its use. Unconjugated bilirubin is attached to an acid, which converts to conjugated direct bilirubin. And that makes it excreted into the common bile duct and the duodenum, and is eventually excreted into the urine and the stool, okay? So sometimes what happens is the bilirubin cannot be, Sometimes the bilirubin can be deconjugated. So in other words, it's conjugated, but then it gets deconjugated. In other words, turned back into unconjugated. And then it will be reabsorbed into the intestines and back into the liver. So that can be problematic. The unbound bilirubin permeates in the extravascular tissues, resulting in jaundice. So the unconjugated bilirubin is what causes the yellow coloring in the skin in our babies. Total bilirubin is the sum of the conjugated direct and the unconjugated indirect bilirubin. So jaundice can be a concern with our babies, okay? It is a risk. Physiological jaundice is not pathological typically, okay? Unless the bilirubin levels get too extremely high and are not treated. But physiological jaundice occurs because the newborn has a higher rate of bilirubin production. Okay, so they're breaking down those red blood cells more rapidly, okay, which causes the breakdown of the red blood cells is what causes bilirubin, okay? And also it is reabsorbed from the small intestine, okay, more rapidly. So hyperbilirubinemia, which is high bilirubin, is almost exclusively of the unconjugated variety, okay? So high bilirubin happens because of that unconjugated, the type that cannot be excreted in the urine and stool, okay? Serum levels will be approximately 6 to 7 milligrams per deciliter when you start to see the yellowing of the skin, Okay. It occurs in about 60%, okay, so more than 50% of the full term and 80% of the preterm newborns. So real frequently in our preterm babies. But the big thing is it happens after 24 hours, okay? Which means if it happens after 24 hours, it's not pathological, okay? And we'll talk about the difference. Pathological would be the RH negative and RH positive incompatibility factors. Sorry. So when we look at babies to determine, whether they're having any signs of jaundice, jaundice will always start in the head and work its way down. So we're going to look in the face. We're going to look in the whites of the eyes will turn yellow, and the mucous membranes. So how we can assess it is just blanching the forehead. And when we do that, the color that we see when we lift up will have a yellow tint to it. Okay. Or, the whites of the eyes will look a little yellow. So again, it starts in the face and works its way down. So peak bilirubin levels are reached at 3 to 5 days. So a lot of times when their babies are discharged, we don't see any signs of jaundice. So that's why we need to teach our moms about the signs of jaundice. Also, the pediatricians see them and they do a weight check and they do a color check to make sure those babies aren't becoming jaundice. Universally, they are checking all babies before discharge. They're checking their transcutaneous bilirubin. Okay, so in other words, they do the transcutaneous bilirubin scanner on the babies to make sure. And what they look at is how old the baby is and what the 95 percentile of babies would be at that particular age to see if they're at low risk, moderate risk, or high risk of developing jaundice. But the typical color changing doesn't typically occur until 3 to 5 days. So that's why routinely the babies are going in a few days after they go home to see the pediatrician. In our preterm babies, the peak is about 5 to 7 days after birth. A dangerous complication of neonatal hyperbilirubinemia is kernicterus. Okay, that is where the level gets dangerously high. Okay, and can cause neurotoxicity. Okay, neural damage. So if bilirubin isn't monitored, and the baby, it becomes jaundice and, level reaches dangerous levels, it can lead to neurotoxicity, which can cause cerebral palsy in the baby, epilepsy, mental retardation, and those things can occur if the baby survives. So this is very dangerous. So definitely we want moms to be aware, to watch for those signs and symptoms, and definitely notify their pediatrician if they worsen. But definitely the pediatricians are seeing those babies after they go home within a few days. Another type of jaundice can occur, which is called breastfeeding jaundice. And it's thought that in our breastfeeding babies, when they become jaundice, it's due to the inadequate intake. Colostrum is awesome, but there's not a lot of it. Okay. So sometimes they're, on the little, they're not getting enough fluids because of that. So that can cause breastfeeding jaundice. What moms need to do that are breastfeeding are feed frequently. Okay. Every 2 to 3 hours to help avoid this from occurring. Okay. Because there's not as much colostrum. They need to be feeding more frequently so that baby doesn't get an inadequate amount of fluid, which causes the breastfeeding jaundice. But breastfeeding jaundice also should not occur, does not occur until after 24 hours. And it peaks also about the third day. So with physiological jaundice, typically, if treated and monitored, the infant will be fine. Okay, so I had that in there twice. Okay. Typically, serum concentration of unconjugated bilirubin that causes the problem does not get any higher than 13 to 15 milligrams per deciliter. Okay. And, we can get those down. And we'll talk about the treatment in just a second. And so typically it doesn't exceed 13 milligrams per deciliter in our newborn or our term infants and 15 milligrams per deciliter in our preterm infants. But we just have to be monitoring, and we'll talk about the treatment for high bilirubin. Okay, elevating bilirubins. So how can we manage this? We definitely want to keep their temperature at or above 98 degrees, 97.8, 98 degrees, not too warm though, to prevent cold stress, because cold stress does cause elevated bilirubin to happen. We want to monitor the stools, because that is how bilirubin is excreted, through the stools. So we want our babies to have frequent stools. Not stooling can lead to that reabsorption of the bilirubin, like we talked about. So we definitely want our babies to be having stools. The great thing is, if mom's breastfeeding, the colostrum is a great laxative and helps, Mother Nature's best, helps get that stool moving so the bilirubin can, not elevate, come out through the stool and decrease. So we want our moms that are breastfeeding to early feed, and then every 2 to 3. And yeah, that colostrum is great laxative. If the bilirubin reaches a concerning level, and it depends how old they are, what level they are. We used to, had a magic numbers when I worked in the nursery, but now they've got it very well gauged as far as they put in how many hours the baby is and what the level is. And, like I said, is it a low, moderate, or high risk? If they become concerned, they're going to put them under the Billy lights. So it's called phototherapy. And this is where the baby is exposed to high intensity lights. And that helps break down that unconjugated bilirubin, so it can be passed through the urine and the stool. So the babies all the clothes are taken off. They can stay in the mother's room for this if it happens while, mom is, if it happens and the baby has to come back in, the mom can usually room in and stay with the baby, but, or in the nursery, this can happen. As you all picked up on, we don't really have an open nursery. So after discharge, these babies would go to the pediatric unit, but they can be treated at home also with Billy blankets and Billy belts. So it's unless it's seriously high, they might even be able to treat them at home. But anyway, the baby has to be put under phototherapy, under the Billy lights, unclothed in just a diaper, and turned every 2 hours with eye protection patches over their eyes. Babies don't like this. Babies like to be swaddled. Babies like to be held. So it's not great, but so sometimes our mothers struggle to have them under the lights, but we need to reinforce that, the longer they're under the lights, the quicker that bilirubin's going to drop down, and then you can be holding your baby again. But, taking them in and out of the light is not going to help them break down that, unconjugated bilirubin that needs to be broken down so they can pass it. What we'll see when we know that the phototherapy is working well is that we're going to see those stools, and they're going to be darker. The bilirubin's coming through in the stools. And we will also see that their urine has a darker tint to it also. And then, we can be very encouraging to mom that, hey, baby's passing this bilirubin. And of course, they're going to be doing bilirubin checks on these babies, depending on the level, at least once a day to make sure that those levels are dropping. Okay. And once they start dropping, they usually continue to drop. So that's a little bit about phototherapy. Okay. All righty. I'm going to start timing out, didn't I? Okay. So it's 12:10. Why don't you guys take a 10-minute break and come back? So I've got 10 after, so come back at 20 after. We'll get started again. Any questions? Let's see. Let me pause it instead of stop it this time. Okay, no questions? All right. Well, I'll see you back here in 10 minutes then. Okay, gastrointestinal system. So our babies are born with the ability to swallow, digest, and metabolize and absorb simple carbohydrates and emulsified fats. We may see Epstein pearls in the baby's mouth, and they're just little normal finding, little yellowish. They almost look like pimples, but on the palate of the mouth or on the gum line. And that's just a normal finding that we see. Cheeks are full of sucking pads when babies are born. Sucking is not developed in infants born before 32 weeks gestation, but sucking in a full-time baby is definitely present and is coordinated with their breathing and their swallowing. They can coordinate their sucking, their breathing, and their swallowing. And they'll do small bursts of sucking. They'll suck 3 or 4 times and swallow, and suck 3 or 4 times and swallow. Teeth develop in utero and continue forming until 10 years of age. Of course, our newborns aren't typically born with teeth. There have been some cases of babies born with teeth. So it is something we should check out on our babies to make sure that they don't have any teeth. If they do, if they're born with teeth, many times the pediatrician will advise the parents to have them pulled, because if they fall out, the baby could choke on them. But I've never seen that happen, but I have heard of it happening. Of course, bacteria is not present in the gastrointestinal tract at birth, but is soon introduced after the newborn's oral cavity is exposed to the environment. So as soon as they're born practically and they start feeding, they're exposed to bacteria and they start developing their own GI bacteria, the good kind. Meconium is passed, of course, and within the first few hours, if they haven't by 24 hours, we're a little concerned, but usually it's much before that, typically. And what meconium is, it's that, dark, sticky, tarry looking stool. And what it consists of is it's amniotic fluid, intestinal secretions, and cells. All that is what's in the meconium stool. So when they pass that first meconium, it is sterile. And then after that, the following stools do contain bacteria, but the first meconium stool is sterile. They can hold about 50 to 60 milliliters in their stomach. We don't like to feed our babies that much if they're bottle feeding. We'd like to start them out with a small amount, so it doesn't cause them to regurgitate that, spit up a lot. So typically we only feed our babies about 30 milliliters to 45 milliliters, an ounce to an ounce and a half in the first few days after after they're born, but they can hold up to 2 ounces. Stools vary with our newborns, and as long as it's soft, there's no concern about constipation. So again, the meconium is the first, the dark, tarry looking black to dark green stool. Then the babies start having what we call transitional stools. And this is a thinner brown to green stool. And sometimes it has a little meconium, and it's part meconium and it's part fecal matter. And they do the transitional stool for about 1 to 2 days. Then our stools change over, baby stools change over to breastfed type stools and formula stools. So breastfed stools are more the pale yellow and maybe pasty or maybe pasty green. And they're more liquid and more frequently. So in the beginning, these babies might have a stool with every feeding. And then they slow down as they age, as they get older. Formula have a paler consistency of about paler yellow and the consistency of about peanut butter. So when we look at the renal system, they have no ability to concentrate their urine. They are only able to concentrate their urine at about 3 months. The urine should be straw colored and odorless. It may be a little cloudy, and that is due to the mucus that is expelled after birth. Sometimes we will see in our female babies what we call pseudomenstruation. And this is just a little bit of blood in the wet diaper that we'll notice. And that is due to the mother's hormones. And, will stop, maybe just be a one-time deal. But that could be something that we see in the baby's diaper. May also see what we call brick dust or spots from urates or uric crystals that come through in the urine. Typically, they're voiding about 2 to 6 times in the first 24 hours, and then after that, 5 to 25 times during subsequent 24 hours. So chapter 24 is about assessing our baby. So of course, we're going to be assessing our baby right after birth. And of course, if we need to, implementing resuscitative measures. We're also in the 1 to 4 hours, or actually right at delivery, we will start, looking at their gestational age. It should match up with their dates, but, sometimes they're a little off. But definitely looking at their gestational age. If they're not full term, then there'll be careful assessment of their gestational age. And, some of the things they look at with gestational age is their resting position. As I said, with our full-term babies, they're in the flex position. With our preterm babies, they're more like frogs. Their arms are out, their legs are out. They don't have that flex position. We'll also see babies that are premature with more vernix, more lanugo, and that fine downery hair, more of that on their shoulders and their back. We'll look at their sole creases, and they won't be over the total sole of the foot. Okay, that can indicate that they're premature. And as I said, the ear cartilage, if their ears don't snap back right away, then, or spring back, I should say, they could be immature, sign of immaturity. In our males, the size of the genitals and the testes may be undescended or typically are undescended. In our females, the labia majora does not cover the labia minora and the clitoris. So that's a sign of prematurity. So those are just some of the findings that you'll see that indicate gestational age, prematurity. And they can use a tool to graph that out to figure out how what the exact gestational age is. One of them is called the Ballard's tool. Also, you're going to be watching our babies in the first 1 to 4 hours after birth, how they're adapting. Make sure they're not having any problems adapting to the outside world. Then within the first 24 hours, there's going to be a detailed physical assessment, physical evaluation by either the pediatrician or the pediatric nurse practitioner will come in and do her head to toe assessment. Of course, we nurses will be doing our assessment too and letting them know, letting the pediatrician and nurse practitioner or neonatal or pediatric nurse practitioner if there's any issues. We're going to also make sure that they're eating well. So we're going to evaluate their nutritional status and make sure that they're, feeding frequently. We're not as rigid as Miss Kimber Shive said about saying you need to feed this baby every 2 to 3 hours. But we do say that they need to have 8 to 12 feedings in a 24-hour period. Okay. So that would equal out to, 3 to 4 or every 2 to 3 hours feeding them. So, sometimes or a lot of times our babies cluster feed and they feed frequently through the night, but then they don't feed, then they go into a sleep pattern and don't feed. So we're not as rigid about, you got to wake that baby up and feed that baby. Now, if hours go on and they haven't woke up that baby, we'll encourage them to wake up that baby and try to feed the baby. Okay, so also, with the assessment, there is a lot in this chapter. Don't worry about knowing all the different things to look for in the assessment. What you need to focus on is the newborn physical assessment checkoff sheet that I went over with you in the demonstration. So know what's on here, know the normal findings, the normal vital sign ranges, and you'll be good to go. Okay. All right. So when we look at the integumentary and the head, the integumentary, we've talked about the acrocyanosis, the blueness of the hands and feet, and it can appear the first 2 to 6 hours after birth and is, considered normal up to 24 hours. And that's just because of the immature peripheral circulation or sluggish peripheral circulation, and that will resolve. And their hands will also feel a little bit cooler, and that's okay as long as their body temperature is warm enough. Some variations we'll see in the head is the first one is the caput. We call it the caput, but the caput succedaneum is the edema of the scalp, and if you think of a cap, it's typically on the occiput of the head. Okay, so it's like a little cap, and this is just a fluid filling or fluid protrusion on the head that is just from the trauma of that baby's head pushing against that cervix during the labor process. And the big thing, the difference between that and the cephalohematoma is it crosses the suture line. So it sits right here like a cap. And then there's suture lines, of course, throughout the head. So we identify this as a caput succedaneum because it crosses the suture lines. Okay. And it'll disappear in a few days. So we can reassure our mom that that swelling will go down in a few days. The cephalohematoma does not cross the suture line. So you see in this picture how it's on the side of the head, where this caput succedaneum is covering, the occiput, so crossing suture lines here, okay? But here, the cephalohematoma does not cross the suture lines. You can't really tell that there is blood underneath there because it is between the skull and the periosteum membrane. So it will look the same as a caput, but it will just be on the side of the head. Babies can have them on one side of the head, or they can have them on both sides of the head, okay? But that is blood-filled, protrusion on the head, a little soft, squishy spot, okay? It takes a little longer for that to resolve, about 3 to 6 weeks. And with the caput succedaneum, since there is blood underneath there, it can cause jaundice to be worse, okay? Because the baby has to break down all those blood cells underneath there also. And they, of course, convert to bilirubin when they're broken down. So that can cause babies to be jaundiced. So we watch for jaundice in babies who have cephalahematomas, okay, as they resolve. Then we've got our anterior fontanelle, our diamond shape fontanelle in the front, and that should be flat, and it shouldn't be sunken, or it shouldn't be protruding. If it's protruding, that's increased intracranial pressure. If it's sunken, that's a sign of dehydration. So we want to sit our babies up and lightly, rub over that, make sure it's not palpating or it's not protruding. You might feel a little palpation actually in those, but make sure it's not, protruding out or sunken. And it closes it takes a while for the anterior fontanelle to close, about 18 months. We would expect that to totally close. The posterior fontanelle is a lot smaller, the little triangle shape back here. And it closes, it's much smaller, and it closes like 8 to 12 weeks. Okay. So we can tell moms that. Okay. With our skin also, the vernix in utero kind of protects that baby's skin because they're sitting in water, so it's a protection to their skin. But by the time they're delivered, again, if they're full term, they shouldn't have a lot of vernix on their skin. Once that is removed, a few days after birth, babies will typically have some peeling of their skin, and that is normal. So of course, our full-term babies have less vernix, and our preterm babies have more vernix. Our post-date, like after 42 weeks post-dates, 2 weeks after the typical gestation of 40 weeks, we can tell that when they come out because they have no vernix and they have peeling skin already. And there's more signs, which we'll talk about later. But that's one of them that can, tell us, oh, this baby's overdue. Okay. Another finding on the skin, which I pointed out to a few students, is milia. And typically you see it on the bridge of the nose, across the nose. And it's just little white bumps, kind of look like whiteheads. But that is normal, and we want to make sure our moms know not to squeeze those, that they will resolve on their own. But they're just small, distended, white sebaceous glands on the face. So cute little white spots on their nose. Some other skin variations. I talked about the Mongolian spots. Those are in our darker complected cultures in their babies. And where you typically see those are over the coccyx area on the back, can be on the shoulders, can be on the arms, but typically over the buttocks area, you'll see a little darker area, and that's just increased pigmentation. And they will fade, but sometimes, they don't fade all the way. Um, then there's different nevi, like birthmarks that we're going to look for. One little benign nevi is the teleangiectatic nevi. That's a big word for stork bites. That's why we call them stork bites. And they're just pale pink or red spots. And we'll see those typically over the eyelids, at the nape of the neck. Okay. And those are called stork bites, sometimes on the nose. Then there's another skin finding that we will see is erythema toxicum. And this is common also in newborns. And it is also called newborn rash because we don't like to say erythema toxicum all the time. So newborn rash. And these areas are little red bumps with white centers. They almost look like little bug bites. And we need to let our moms know that's normal finding and they will resolve without any intervention. Okay, so there's some skin variations. Okay, if we look at the baby's head some more, we may see molding. And you see this, I don't know if none of you are probably old enough to remember the cone heads on Saturday Night Live, but maybe you've heard of them. And that's where the baby's head is very pointed, and that can be alarming to the moms. So we always say, it's going to resolve. It's going to resolve. Don't worry, in a few days. And usually within a few hours, it's much better, but it may last for a little while. And it's just, the molding of the cranial bones, overlapping of the cranial bones for that baby's head to fit down through the pelvis and be delivered. And it's amazing how that can occur, and it doesn't hurt the baby at all. So this is called molding. Okay. Neuromuscular system, we look at a lot of different reflexes to make sure that the neuromuscular system is intact. Babies will have, some spontaneous motor activity. You might see some little tremors in the mouth or the chin, and those are normal. All the reflexes are covered on table 24-4, if you'd like to look at them. But these are the main ones that I talked to you about. The tonic neck is the fencing position. So if you turn the baby, and typically you can't elicit this, so I don't even show you guys this with the assessment in the hospital because it's hard to elicit. Where we see this happen is when the baby's on the radiant warmer. Okay, if they're resting and their head is towards one position, so when their head is towards that position, their arm will be straight on that side, whichever way their head's turned, and their leg will be straight. And on the other side, their arm and leg will be flexed. Okay, just like you would if you were going to be in a fencing match. So that is called the tonic neck or the fencing reflex. Then we have the Morrow, which is the startle. And, what I typically do is have the baby grasp my fingers and just lift them just a little bit. And then, not drop them, but just let them fall just a little bit. And that elicits the Morrow, which they make a C with their hands and kind of shake. Okay. Or you can elicit it with a loud noise, but I prefer to do it that way. Sucking, when we're checking for the palate in the mouth to make sure the palate's intact, typically those babies will start sucking, but we want to check and make sure the sucking reflex is intact. And the rooting is elicited if that baby's hungry. It's hard to elicit if they're not hungry. That if you rub their cheek, they'll go towards that direction, and that's to help them find the breast with breastfeeding. Grasp, I talked about, they'll grasp your fingers, and if you put your finger on their toes, their little toes will wrap around your finger. Okay, so that's the plantar, so the palmar grasp and the plantar grasp. I call them little monkey feet because that is supposed to be a primitive protection for those babies to kind of grasp onto mom. The Babinski is where we're rubbing the bottom, the sole of the foot up and around, and that causes the toes to flare, and that is the Babinski reflex. And that should occur but should disappear by about 24 months. Now, in an adult, if you had a Babinski, that would show neurological problems, but in a baby, it is normal up to 24 months. The gallant is where the baby, I hold the baby face down and I rub one side. You want to make sure the spine's straight and take your finger, nail side, and rub up the side of the spine, and that baby will curve their hip towards the direction. Okay, so if I do it on this side, they'll curve their hip this way. If I do it on that side, they'll curve their hip that way. And that is called the gallant, or the trunk incurvation reflex. Okay. All righty. Normal newborn needs after delivery. So it is legally required for nurses to administer eye prophylaxis or eye treatment. So all neonates get it unless the parents refuse it. But typically we're using erythromycin, but there's other ophthalmic ointment, antibiotic ointments that can be used, but that's the one I've seen the most, erythromycin. And it prevents the transmission of gonorrhea and chlamydial infections from the birth canal getting into the baby's eyes, which can cause blindness. So that is why it's, federally mandated that all babies get that antibiotic ointment. It can also it can also prevent other infections in the eyes. Some babies have a little irritation from that eye ointment, but it's given to all babies unless parents refuse. And it's put right down in the lower part of the eyelid. You just pull the eyelid down, you squirt it down in there. Okay. Another medication that's given to all babies is vitamin K, and prophylactically, or aquamaphytin. It's just a single injection, about 0.5 to 1 milligrams. And this prevents hemorrhagic disorders in the newborn. And it's given in their little leg, their vastus lateralis. And again, that's given because that baby does not have the normal bacteria in their bowel when they're born. And that is what synthesizes the clotting factors, blood clotting factors. So we give them a little boost of vitamin K to get them through that period where they, don't have that gut bacteria to synthesize the clotting factors. So it gets them over that hump. Cord care, of course, we used to do alcohol on the cord. We used to do triple dye, which turned the cord blue to help dry it up. And studies found that, it really didn't make a difference, that if we just leave it alone and just clean around it and keep that cord clean and dry, by keeping that diaper folded down below the cord, that it will heal just fine. The clamp that's put on initially after delivery, is there until the cord dries enough that the cord clamp can come off. Well, it should be pretty dry before we take the cord clamp. No babies go home with a cord clamp. So it usually takes like 24 hours for that cord to dry up enough that we can take off that cord clamp. So 24 to 48 hours will remove that cord clamp. Okay. And anytime we're looking at the cord, of course, we're watching for any bleeding or signs of infection, any redness, any drainage around that cord. So, and of course, we'll be teaching our moms what to look for if that cord needs to be treated, if they need to be seen by the pediatrician about the cord. Okay, well, I have 12:50, so I guess we will pick up with CERT care on Wednesday. I will get up the last two sets of PowerPoints. Probably not, I'm sure not until tomorrow. But let me stop, share my screen. Does anyone have any? Yes, no, they won't be posted today. And no, there's 2 more sets of PowerPoints to come, which are, let's see, where are my PowerPoints? Okay. So there's a part 3 and a part 4. Part 3 is about high-risk newborns and interventions, and it is about 24 slides. And part 4 is about, well, the first slide is about fetal alcohol syndrome. Okay, so some abnormalities in the fetus. Okay, and there are 17 of those slides. So 2 more sets that I will get up for you. Definitely the next set by tomorrow, and I'll try my best to get both sets up tomorrow. Okay. What other questions do you have? Oh, okay. Oh, I'm sorry. Okay. You have to wait to print them at work. Yeah, printing's an issue, huh? Okay, we just stopped at, we're going to pick up at 25, slide 25. We finished 24. We're going to start at 25. Okay. Any other questions you can think of? Oh, shoot. I don't know if I was recording, guys, the last few slides. Darn it. All right, well, last few slides might not be on there. I need a little reminder person. Tell me to start the recording. I may have just turned it off. All right, well, if there's no other questions, I will let you go, and I will see you guys on Wednesday, and I'll